So in this assessment, we are going to be assessing the thorax, the lungs, and the cardiovascular exam, considering taking advantage that we are going to be in the area. So to begin with, we are going to inspect and then palpate. We're looking for any masses, any lumps, any tenderness that is present. I am going to explain to him beforehand, before laying hands on him, so that he is aware that what I am going to do. Ideally, he would have his shirt off so I could inspect his skin, which I can do, and check if there's any moles or anything that is out of the ordinary, such as lumps or masses. So after inspecting the skin and it looks nice, pink and moist, I am going to palpate to search for any masses. So some light palpation, and was there any tenderness? Did it hurt? There was no pain or tenderness, no lumps or mass is present. So I'm observing his breathing. There's no labored breathing. There's no sternal retractions or accessory muscles being used during the breathing. So I am going to go ahead and listen to lung sounds. I'm listening for adventitious lung sounds which are abnormal, such as crackles that sound sort of like Rice Krispies when there's water in the lungs, wheezes, or friction rub when the two sacs are rubbing against each other, or stridor when there's an obstruction. So I'm going to go ahead and listen for that. We're listening to the lung sounds. I am going to start at the apex of the lungs and move my way down towards the upper lobes, the right middle lobe, the right lower lobes, and the left upper lobe and the left lower lobe. Take a deep breath every time, right? Deep breath. Deep breath. Okay. I'm at the second intercostal space. Deep breath. Okay. Deep breath. The fourth intercostal space. Deep breath. Deep breath. I'm gonna go down to the right lower lobe, left lower lobe, and we're gonna do the lateral sides. So we're gonna go down to the sixth intercostal space at the mid axillary line. So you could raise, okay. Deep breath. Raise your hand. Deep breath. Okay. His lung sounds were clear. There was no crackles, wheezes, or friction rub or stridor present, and there was no labored breathing also noted. We are going to go ahead and finish our assessment in the front. So we are going to assess heart sounds. And as I go, I will be naming the landmarks that I am going over. So for his heart sounds, we are looking for the normal heart sounds, which is S1, S2. We would listen, if I had a stethoscope with a bell, with the diaphragm and the bell to assess for any murmurs. I assessed the carotid arteries in a previous assessment, but I am still going to go ahead and palpate them separately. And he has a +2 pulse bilaterally, and I would go ahead and listen for bruits over his carotid arteries using the bell of the stethoscope. So there are no bruits present, so we're going to go ahead and auscultate the heart sounds. So we find the atrial, where the atrial valve is, which is to the right of the sternal border. We find the angle of Louis, and it will be around the second intercostal space. So we find the second intercostal space to the right of the sternal border, and this is the atrial valve. You can hear lub dub and S1, S2, and S2 is the loudest over the aortic valve. So we just move over to the left of the sternal border, and we're over the pulmonic valve. And we also hear S1, S2. So we go down to the third intercostal space to Erb's point. We hear S1, S2. We go down to the fourth intercostal space where we're over the tricuspid valve, and we hear S1 louder. And we move down to the fifth intercostal space, mid-clavicular line, and right here we are at the point of maximal impulse, also known as the apical pulse, and we are over the mitral valve. We would listen to the apical pulse for a whole minute, and his apical pulse was, the normal apical pulse is between 60 to 100 for an adult, and his was at 70. If we were to have listened a whole minute, it was at 75, 74. So we would switch also to the bell of the stethoscope. My stethoscope doesn't have one, but we would switch over to the bell and go over the same landmarks to listen for murmurs or anything else of that sort. So now I'm going to ask if you could move to the side so I could look at your back. And again, I would begin the assessment by inspecting his skin in the back. I'm just gonna raise it a bit. I would note for any scars, lesions, any moles that are of abnormal shape. I'm going to go ahead and palpate and note for any masses on his back or tenderness. I'm going to go ahead and percuss and note how it feels flat and duller over the bone area, and there's more tympany around the lungs. Is there any pain? Do you feel any pain?
No.
There's no pain over the kidney areas. And we're gonna go ahead and auscultate his lung sounds from the back. So we start again at the apex. Deep breath. Okay. Deep breath. So we find C7, which is usually the one that's protruding, and we go down to T3, and that's where we would start sort of the left upper lobe and right upper lobe. All the way down to T10 approximately. Alright, so his lung sounds in the back were also normal. There was no adventitious lung sounds, and that concludes our thoracic and our lungs and cardiovascular portion of the assessment having to do with the chest area.